Assalamu alaikum, everyone. Hello, everyone, and warm welcome to today's session on Pharmacotherapy Specialist Role in Addiction Rehab Center. Thank you for joining us. My name is Muhammad Tashtoush. I'm the Pharmacy Section Manager at the National Rehabilitation Center, Abu Dhabi, United Arab Emirates. While we're waiting for a few more of our colleagues to join, please allow me to brief you a little about ISSUP. ISSUP is a membership organization with over 20,000 members worldwide, working in a field of substance use prevention, treatment, and recovery care. If you have not done so already, please head over our website, issup.net, where you will find an information on how to sign up for free membership and information. Our website also has a wealth of resources and publication for you to enjoy regarding the substance use disorders. You can also watch a recording on past webinars and see future event listing on our website. I would like to thank you all and thank ISSUP staff for providing technical support on this event. Today, our journey will dive into Pharmacotherapy Specialist Role in Addiction Rehab Center. Our speaker is a distinguished pharmacotherapy specialist, Dr. Ibrahim Khafaji. He's assigned currently the pharmacotherapy specialist at the National Rehabilitation Center, Abu Dhabi, United Arab Emirates. A very warm welcome to all of you, and it's a great pleasure to have you with us today. Let me introduce Ibrahim Khafaji briefly. Ibrahim Khafaji, as I mentioned, is currently assigned as the pharmacotherapy specialist in the pharmacy section at the National Rehabilitation Center, Abu Dhabi, United Arab Emirates. Previously, he served as a lead pharmacist at Al Ain Hospital. He was responsible for providing the medication therapy management services to the Mental Health Institute. With more than 15 years experience in a various hospital pharmacy setting. He's a board certified in pharmacotherapy and board certified in medication therapy management. Additionally, he holds a certification as a professional in healthcare quality, CPHQ. He is also a graduate of the Principles and Practice of a Clinical Research program by Harvard. Today, Dr. Ibrahim will brief us so far on 4 key pillars. I'll start with how to start pharmacotherapy services in addiction rehabilitation setting, the key role of pharmacotherapy specialists in addiction rehabilitation center as part of the integrated and multidisciplinary care. He will explain to us the difference between the pharmacotherapy specialist role in rehab center versus acute care setting. And he will highlight the main responsibility of the pharmacotherapy specialist role within the multidisciplinary team in the rehab center. Before we get started, I would like to go over a few items so you know how to participate in today's events. You will have the opportunity to submit text questions to our presenter by typing your question into the question pane of the webinar interface on your screen. You may send as well your question at any time during the presentation. We will collect these questions and addressing them in the right time in the question and answer session by the end of today's presentation. Webinar and online events delivered and hosted by International Society of Substance Use Professionals are provided for information purpose only. They are education in nature and do not constitute of medical advice, diagnosis, or treatment. A recording of this webinar as well will be made available for all of you to watch on demand after this event. We hope we will stay with us, all of you, for what promises to be an illuminating session with Dr. Ibrahim. You will take away from this, if nothing else, a much more informed perspective about the pharmacotherapy role in addiction rehab center. And now it's my pleasure and an honor to hand over to our speaker, Dr. Ibrahim, and welcome him on board to our webinar. The floor is yours, Ibrahim. Go ahead, please.
Okay, thank you, Dr. Muhammad, for this introduction. I would like to first thank ISSUP UAE chapter for this opportunity to deliver our presentation today about the role of pharmacotherapy specialists in addiction rehabilitation center. I would like also to thank ISSUP for their technical support during this presentation. So today, thank you all for giving us this opportunity to be with you today. So today our presentation about the role of a pharmacotherapy specialist in addiction rehabilitation center. So to break the ice, I want to start with first poll for today. So Kodo, please, if you can just share the first poll with our attendees. So do you provide the pharmacotherapy services at your facility?
So feel free to select your current setting in regard to pharmacotherapy service at your facility, please. Either yes or no.
So can we have the result now? I think Okay, this is very fantastic. Yani 67%. They have the pharmacotherapy services, which is a very crucial services, in my opinion, to be available, and it will add value-based services at the facility. So this is very good. 67%. This is very interesting. So let us start our journey today with our presentation. So my objectives. Can you see my slides, Dr. Muhammad? Yeah, I think yes.
Yes. Not yet.
Yes. So
yeah, now it's okay. Go ahead.
now it's okay. Okay, thank you very much. So my objectives for today's presentation, I will highlight the role of a pharmacotherapy specialist in addiction rehabilitation center as part of the recommended integrated care to be present in every addiction facility. Then I will go to highlight the difference between the pharmacotherapy specialist role in rehabilitation versus the standard acute healthcare setting. Then I will go to highlight the main responsibility of the pharmacotherapy specialist that he can do within the multidisciplinary team during the delivery of care in the addiction rehabilitation setting. So the expected learning outcomes at the end of my presentation today, we will understand the role that the pharmacotherapy specialist can do within the multidisciplinary team. Then we can know how to start the pharmacotherapy services in addiction rehabilitation setting. And at the end, I will explore the role of the very important two parts of pharmacoeconomics and pharmacogenetics, which I think they are the future in the addiction rehabilitation setting. So let me start first with a pharmacotherapy definition. So the pharmacotherapy, as a basic definition, it is a treatment of health conditions by using drugs as a medication. Pharmacotherapy can be of a high quality when the medications are used rationally. That means the patient should receive the right medication at the right time, and he should use them in an appropriate manner, then to have the maximal benefit from them in the dosage that matching their individual requirement for a sufficient period of time and at the lowest cost to them and to the society. While in substance use disorder or related treatment, we need to tailor the pharmacotherapy definition in this area. So we need to combine the provision of comprehensive medication management services along with counseling and other behavioral therapies as a holistic approach to recovery. Because in substance use related treatment, the pharmacotherapy alone cannot do the job. We need to combine it with other team through counseling, behavioral therapies, all other multidisciplinary team. Then one more important thing, what is the difference between the pharmacotherapy services and addiction rehabilitation setting? In acute care hospitals, our clients are mainly patients, while in addiction rehabilitation settings, we can deal with either healthy patients, which we can name them person served, or on most of the times, we may encounter patients as we have a lot of persons with medical or psychiatry comorbidities. So for such kinds of our persons or our clients, we need to deal with them as a patients, because those kind of clients will need a very detailed and a tailored treatment approach that can guarantee that we'll have the maximal benefit from them without affecting their safety. In acute care hospitals, the goals from the treatment from the pharmacotherapy are easy to achieve through pharmacotherapy alone. While in addiction rehabilitation setting, the pharmacotherapy alone cannot achieve the goals. We need to combine it with all the other techniques and all the other programs that we need to deliver to our patients. In acute care hospitals, the pharmacotherapy guidelines for different diseases and the management are well established, as we have evidence-based guidelines for all or most of the treatments. But for addiction rehabilitation setting, there are still a lot of gaps that's still debatable, and we need to deal with them in different situations. One size does not fit all. In acute care hospitals, in case of relapse, the patients will have the most impact. So if we have a heart failure patient and he is not complying with the treatment, who will have the most impact? The patients. While in addiction rehabilitation setting, the impact of non-compliance or the charge against medical advice, it will not affect the patient alone, but it will affect the patient, his family, and the disasters will reach even to the community. So the pharmacotherapy specialist has a very specialized role in the addiction rehabilitation setting. There are a lot of misconceptions about the pharmacotherapy. So here there are 5 most common myths about medications for addiction treatment. It was published by Dr. Cameron and Dr. Nathan. So the myth number 1, medications for opioid use disorders just trades one addiction for another. While the fact, the ISSUP defines the addiction as a primary chronic disease of brain reward, motivation, memory, and related circuitry. So when the people use it as a substance compulsively and continue using it, even when there are negative consequences in their life, the people with addiction often experience either craving to use a substance as well as withdrawal symptoms when they stop using it. The withdrawal symptoms are extremely unpleasant and have potentially dangerous physical and psychological effect. So both cravings and withdrawals may contribute to cycles where people continue to use a substance and they cannot stop. So now we have medications for opioid use disorders such as buprenorphine or methadone that work in the brain to treat both craving and withdrawal symptoms. These medications do not cause patients to feel high or intoxicated or euphoric, and the goal for medications for opioid use treatment for patients to feel normal so they can live a functional life, breaking the cycles where craving and withdrawal symptoms dominate their life. The myth number 2. There is no proof that medication for opioid use disorder is better than abstinence. This is the myth. While the fact, this is not true. Studies have consistently shown that people with opioid use disorder will return to using opioids about 90% of the time when they do not receive medication treatment and they try to stop. This happens even for people when they go through detox in a rehab or in a hospital program. 9 times out of 10, people will return to using opioids within 1 to 3 months. On the other side, studies have consistently shown that the patients treated with buprenorphine or methadone have much lower rates of returning to using between 40 to 50%, and this is a huge improvement. Studies also have shown that there are other benefits to medications for opioid use disorders, and the patients are more likely to stay enrolled in a treatment program, less likely to be incarcerated, and less likely to acquire infections from drug use, such as HIV or hepatitis C. The pregnant people who treated with medication for opioid use disorders are less likely to have pregnancy complications. Most importantly, the people treated with methadone and buprenorphine are less likely to overdose and less likely to die. So in summary, there is an ample proof that treatment with medication for opioid use disorder is better than abstinence, and it helps save their lives. Myth number 3. There are no medications for the treatment of alcohol use disorders, or only one medication or one pharmacotherapy is available, while in the fact, there are 3 medications that are FDA approved for the treatment for alcohol use disorders. We have naltrexone available as a daily pill or on a monthly injection. We have acamprosate and disulfiram. Both naltrexone and acamprosate, they can reduce the risk of returning to drinking and are generally well tolerated with minimal side effect. Other medications such as gabapentin and topiramate are not FDA approved still for alcohol use disorder, but there is a growing body of evidence that they may be effective. Myth number 4. The patient may say, if I can just get through withdrawal, I will be able to stop using the substance. While the fact is, addiction, we know it is a primary chronic disease of the brain that is not resolved when patients go through the phase of acute withdrawal. And the changes occurring in the brain and body that cause the illness may take months or even years to return to normal. So in the meantime, people may be triggered by other people, places, objects associated with use, emotions, or other experiences. The urges and the craving that drive a person to want to return to using substances may last years despite the abstinence. The last myth. There is no need for long-term medication for addiction treatment. While the fact is, when it comes to treating substance use disorder, there is no one-size-fits-all route to recovery. Stopping treatment too soon may increase the risk of return to use, and it is recommended that each person's treatment course to be based on their individual needs and with shared decision-making with their healthcare provider. And due to the chronic nature of substance use disorders, the need for continued medication treatment should be periodically re-evaluated. Just like other those with chronic medications like hypertension or diabetes, some people with the most severe substance use disorders may require lifelong treatment with medications. So we came here again to the pharmacotherapy. What is the main responsibility of the pharmacotherapy specialist in the addiction rehabilitation settings? So we need first to streamline the medication management process, and one of the most important techniques to streamline the process is to do automation for the pharmacy. And the pharmacy automation, we need to implement many things during the automation, and one of them, the pharmacotherapy specialist can integrate the role of the pharmacotherapy in the pharmacy practice to streamline the medication management process, starting with prescribing, dispensing, and monitoring. Then again, we need to implement and oversee the clinic decision support within the hospital health information system. So once you implement a health information system in your facility, you need to use the clinical decision support system that will guide all the clinical and the clinical team in your facility, including physician, pharmacist, and nursing. So whenever you can have a system that can alert the physician that there is a drug-drug interaction, therapeutic duplications, warning system, whatever you have to guide the clinical decision, the pharmacotherapy specialist can help with this. The pharmacotherapy specialist can participate actively in the development of the clinical pathways within the hospital as part of the multidisciplinary team to standardize the treatment process and even to develop a treatment plans for such kind of patients. And not lastly, but one area that we needed urgently in the field of substance-related disorders is to have a clinical research program in every facility. And that is very important, as we said earlier, that there is many areas that is still debatable. And we cannot reach to the area with evidence-based practices unless we are collaborating at the facility level, then to the local level, and then collaborate with the international level to have an evidence-based practices for substance-related disorder. Then again, we came to poll 2. So please, Kodo, if you can just share the poll 2.
Thank you, Kodo.
Dr. Muhammad? Yeah.
For the audience, I mean, just feel free to assess this statement from your experience point of view.
So do you agree that pharmacotherapy services, it is a value-based services and shall improve the quality of care and expected outcomes? So you can choose either strongly agree, or disagree. So I think we can have the result now. Okay, that is very good. So 63% strongly agree, 35% agree. So that is very good. So I think we will, during our presentation today, maybe this strongly agree will be more after the end, at the end of my presentation. So let's go back to continue the presentation. So I think you can see now the presentation, right? Establishing pharmacotherapy services.
Yes, Ibrahim, yes. Go ahead.
So we came. So now we know that it is a value-based services and it is a very important. But now, if you want to start a pharmacotherapy services, actually there is no standard route to start your services. Whatever you have, according to your facility, according to your resources, you can choose the way you want to start it. So in our case, in NRC, we started with, this is a pyramid. So we start with improving the pharmaceutical care or the pharmacy system. So we started with automations, improving the healthcare information system, and then we'll go to the clinical decision support system. Then again, after you establish a good base of the basic pharmacy services, you can start look for the medication safety and the quality, and you have a documentation system to monitor the effect of the drugs. And then you can go with the pharmacotherapy services, that is to develop the guidelines and the standard treatment and to have the clinical research at the top of the pyramid. However, that if you don't have the basic pharmacy services, or if you have a basic pharmacy service, that is, you should not wait until you have the automation and even the health information system, the electronic system. Even if you have a manual, you can still start with the pharmacotherapy services, because it is very important. And even you can flip the pyramid and you can start with pharmacotherapy, then whatever comes later, it will come either medication safety, quality, and the pharmacy services. Again, by default, it will be improved once the pharmacist shifting the role of the pharmacist from just the dispensary role to be an active member in the treatment team. And I think the physician and the nursing and all the other teams in your facility, they will feel the impact that what the pharmacist can help them in. So improving the pharmacy service process, it is very important, as we said, because we have three main stages in the pharmacy services. We have we can start with prescribing through developing the health information system. And as I said, even if you don't have resources, you don't have electronic system, you have a manual system, but you can just have a system to how to track the manual, how to get the data, how to analyze the data even from the manual, and you can just have the system for this, and that can do the job. Once you implement the electronic system, you can have a clinical decision support system, and advancedly you can use the artificial intelligence that can help and make the process very easy for all the treating team at your facility. For dispensing, you can do the automation, and you can use the decentralized automated dispensing cabinets in the ward to decrease the time needed for dispensing or procuring the drug, or from the nursing to the pharmacy, transfer the drug from one unit to another. So if you have it in every unit and it is decentralized, that will help you and it will ease the process and improve the pharmacy services. Then you can come to the monitoring through, and this is a part of mainly for the pharmacotherapy services. You can establish the policies and the guidelines, and you can have REMS program, which is risk evaluation and the mitigation strategies. And you can start with selecting the more drugs that you may encounter side effects, or you need to monitor their efficacy. So you can have special programs for this. And later on, you can publish your data and you can participate in clinical trials or clinical research. So now we have two areas that is very important for pharmacotherapy to participate in, which is pharmacoeconomics and pharmacogenetics. And I will start with the pharmacoeconomics because it is very important to use your resources wisely and try to accommodate as much patient as you can with your budget. So the aim of the pharmacoeconomics is to compare the economics of different pharmaceutical products or to compare the drug therapy to other treatments. The pharmacoeconomics, it is about making choices between options, weighing the cost and the benefits of option one with those of option two. And there are four types mainly of pharmacoeconomic evaluations, and all of which can be applied to pharmaceutical products. The first one is cost minimization analysis. The second one, cost effectiveness analysis. The third one, cost benefit analysis. And the last one, cost utility analysis. So these four main types of pharmacoeconomic evaluations can be done in your facility by the pharmacotherapy service in your facility. So the pharmacotherapist, if you have pharmacotherapy services, you can do the different types of pharmacoeconomic evaluation, and you can support your pharmacy and therapeutic committee to have informed decisions based on the evaluation you did. And the most important part that the pharmacotherapy specialist can do is to monitor the implementation of the recommendation to avoid the loss of the resources. So, for example, if you have an option one, which is a long-acting antipsychotic injection, which can be used monthly, and you have an option two, which is a long-acting antipsychotic that can be used every 3 months. And from the cost only, you will see that there is, if you transfer from option one to option two, you will have almost 15 to 20% cost reductions. So based on this only, can you just choose option two, or there is a lot of things, or there is many things you can do? So let us watch this video about the new antipsychotic, which can be used every 3 months, the paliperidone palmitate every 3 months. And later on, we can have some discussion. So Kodo, please share this video. So this is about the administration part of this new injection.
Invega Trinza has components and steps for preparation that are unique. Let's start by going through all the contents of the dose pack. Each dose pack of Invega Trinza should include a pre-filled syringe and 2 thin-wall safety needles. Thin-wall safety needles are designed to be used with Invega Trinza. Therefore, it is important to only use the needles provided in the Invega Trinza kit. First, select the proper needle based on the injection area and the weight of your patient. If administering a deltoid injection and your patient weighs less than 200 pounds or 90 kilograms, choose the 22-gauge 1-inch needle with the pink hub. If your patient weighs 200 pounds or more or 90 kilograms or more, choose the 22-gauge 1.5-inch needle with the yellow hub. For all gluteal injections, however, no needle choice is necessary. Only use the 22-gauge 1.5-inch needle with the yellow hub, regardless of patient weight. We've now reached one of the most important steps in preparing Invega Trinza. Please note, Invega Trinza requires longer and more vigorous shaking than Invega Sustenna because it is a more concentrated suspension. Invega Trinza must be shaken vigorously, with the syringe tip pointing up for at least 15 seconds. Proper suspension prior to injection is absolutely essential to successful delivery, so keep your eye on the timer. And follow this technique to make sure you're shaking Invega Trinza the right way. With the syringe tip pointing up, shake vigorously with a loose wrist for at least 15 seconds to ensure a homogeneous suspension. This will also help ensure that the medication is administered smoothly. 3, 2, 1, done. Now check the liquid in the viewing window of the syringe. The suspension should appear uniform and milky white. It is also normal to see small air bubbles. Now that you've properly shaken the suspension, you have 5 minutes to inject it. Proceed to the next step immediately after shaking. Quick note, if more than 5 minutes pass before injection, shake vigorously again for at least 15 seconds with the syringe tip pointing up to resuspend the medication.
Okay, we came back. So this video, I just wanted to highlight that the very important part of the pharmacotherapy specialist can do at your facility. So if you choose to switch from option 1 to option 2, because you will have a 15 to 20% cost reductions, that is very good. But the administration part, which is one part that if you missed it, so most of the patients, if you switch them to the 3 monthly injection, you will end up with relapse, and that will cost you more than that you expected. It is not about the cost of the injection, but the cost of the relapse of one patient. It is very costly. So it is very important once you take the decisions, and you need to implement the recommendations, and through teaching or through educating your team at your facility, because you will not discover it at the earliest. For example, if you switch now from option 1 to option 2, and you will not know that the option 2 there is something happening until maybe 3 to 6 months, because maybe you will not be sure what's going on. If you ask the nursing, they will tell you, yes, we are shaking, but are you shaking properly? No. So if you can see, this is the demo of this injection. So maybe we tried at one facility before that, maybe from the 20, if you have 100 nurse, maybe 2 or 3% at the beginning, they will know. So teaching is very important, and monitoring the implementation of the recommendation is very important to take the wise decision before just taking the decision. So this is one more thing that you can do here. Coming to the pharmacogenomics, which is the future of the healthcare provision. So pharmacogenomics, it is a study of the effect of the inherited genetic variations on an individual's medication response, and it combines the pharmacology, which is the science of the drug kinetics and dynamics of response, and the genomics, which is the study of the entire genome to optimize the medication therapy. So the polymorphism in the pharmacodynamic genes can affect the drug action at its target, such as a receptor, while the polymorphism in the pharmacokinetic genes, such as the cytochrome B450 or metabolic enzymes, can affect the blood and the tissue drug levels. So what is the importance of the pharmacogenomics? So here we have this is what the genetic report of one patient can do if you are doing the pharmacogenetic at your facility. So this is a report legend I just highlighted. This is very basically, so this is a major drug. If you have a major drug interactions, moderate, this is the red one, the yellow for the moderate gene drug interactions, the green for the minimal, and this is the icon legend on the right side, when you can see that this medication, the star, if you have an FDA evidence, because the FDA has published recently a table of pharmacogenetic associations, and plus that means you will have more increased exposure to the drug due to pharmacogenetic interactions. The minus, you will have a decreased exposure. If you go back, so as a summary, so now if you have this is a gene and the phenotype summary. So let's metabolizer, normal metabolizer, rapid metabolizers, or ultra rapid metabolizers, and also the gene going for example, HLA-B negative, as you can see in the down here, this patient. So for this patient, if you can just see cytochrome B2D6, you will find this patient, his ultra rapid metabolizer, and his HLA-B is negative, which carries a normal risk. So this patient HLA-B negative and cytochrome B2D6 ultra rapid metabolizers. So how this will be important for you? So yeah, so here you will have a genotype predicted interactions for medications, and the full gene report will provide you for all the medications in every different section, psychiatry, cardiovascular, anything, it will be distributed. This is for psychiatry, and I will just take the example of paroxetine from the major gene drug interactions. If you can see here, there is a minus. So as in the previous slide, I told you this patient, it was cytochrome B2D6 ultra rapid metabolizers. So because of cytochrome B2D6 ultra rapid metabolizers, he will have a decreased effect of paroxetine. So at the beginning, if you have a gene report from for these patients, you know you will tailor your choice according to the genotype of this patient. So you'll not choose paroxetine, for example, and you will go for other options which has minimal drug interactions. For minimal gene drug interactions, I choose here carbamazepine. There is, if you can see, there is a star here, and the star, I told you, there is an FDA table of genetic associations. If you went to the table from FDA, you'll find that it is recommended to have HLA-B screening before starting the drug, because if the patient is HLA-B positive, he may carry a significant risk for developing Stevens-Johnson syndrome. So imagine if you start a patient and he can develop this Stevens-Johnson syndrome and you don't know what is the reason. But if you have his gene profile, you can wisely choose the medication that it will have the maximal benefit, and also at the same time with minimal side effects that it will not affect. It will protect him, and it will not affect his safety. So in UAE, we have a UAE Genome Project, and this is a great program which aims to explore the genetic makeup of our nationals. And the expected result from this program, you will have the successful outcome of the program will equip all the healthcare practitioners with quality information that will enable them to provide an advanced diagnosis, treatment options, and a personalized, and this is the most important, you will have a personalized and preventive programs tailored to an individual's unique genetic makeup. And it will also help to predict and prevent the present and future genetic diseases better and implement new therapies for rare and chronic diseases. So as now for the pharmacogenetics related to the opioid agonist treatment, just this is a case scenario. So you know that opioid agonist treatment is an integral component of opioid use disorder management. Buprenorphine is often utilized in the opioid use disorder management due to strong clinical evidence of efficacy. However, inter-individual genetic differences in buprenorphine metabolism may result in variable treatment response, leaving some patients undertreated and at increased risk for relapse. The clinical pharmacogenomic studies the effect that inherited genetic variations have on drug response. So patients who reported discomfort at daily buprenorphine dose of 24 milligram, which was the mandated daily maximum dose, regular urine screening were conducted to detect the presence of any unauthorized substance, and it was clear. At the 24 milligram buprenorphine daily dose, the patient had multiple relapses with unauthorized substances. The pharmacogenetic testing revealed that this patient exhibited a cytochrome P450 ultra-rapid metabolizer phenotype, which necessitated a higher than recommended daily dose of buprenorphine 32 milligram for adequate opioid use disorder management. The patient exhibited a reduction in the number of relapses on pharmacogenetic-based dose recommendation compared to standard dosing. So as a conclusion, the pharmacogenomic testing as a clinical decision support help to individualize opioid use disorder management, establishing genetic polymorphism database with a greater proportion of underrepresented population to improve health equity in pharmacogenomic testing algorithms, developing clinical pathways for the use of pharmacogenomics at the bedside by using aggregated pharmacogenomic data to predict the appropriateness of the testing. It is reasonable to conduct pharmacogenomic testing prior to the initiation of buprenorphine naloxone therapy in order to determine an appropriate starting and maintenance dose. The use of clinical pathways can help with cost containment by limiting the use of pharmacogenomic testing to instances in which it is deemed medically necessary. Redefining pharmacoeconomic analysis for opioid dependence cost by taking into account the use of pharmacogenomic testing and the saving associated with the prevention of downstream costs that can be ameliorated with customized medicine. And here we reach to the end of my presentation, and thank you very much for your listening.
Thank you very much, Brahim, for the informative lecture. And
thank you, Dr. Muhammad.
Why we're just waiting and until just receive some question. We have received, I can see one question as of now. We're now going to begin the answering for a question submitted through the question panel, please. So feel free to submit your questions. And a reminder, you can still submit your question even during this time as well. So just to highlight what Dr. Ibrahim highlighted about the role of pharmacotherapy specialist in the rehab center, especially for the addiction. As I mentioned, and we're always saying that the pharmacotherapy specialist can be the key link between the multidisciplinary team in the center. As of now, we have one question, Ibrahim. What do you use for amphetamine and dextroamphetamine for?
Again?
What do you use amphetamine or dexamphetamine for? Not sure. Maybe it can be rephrased from the attendees who asked the questions. Chat again. There's so maybe a question, Ibrahim. I mean, how do you believe that the pharmacotherapy specialist will support the pharmacist role as well as the nursing team in providing the guidelines in a prospective approach, I can say?
Yeah, the presence of the pharmacotherapy specialist, first of all, if you have a standard guidelines at your facility, so that will be for all.
Sounds breaking.
All the treatment options that will it will be standardized, so all the healthcare providers, either physician or so if there is any variation happened by mistake during prescribing, during administration, it will be the other barriers, like Swiss cheese model. So we'll have different barriers. So if the physician by mistake bought a different an order by mistake, it will be discovered by the pharmacist, and even if it passed by the pharmacist after validation, if the nurse is well known about this standard treatment, he can discover it, and that's before reaching the patient. Then we can correct it, and it will we will protect the patient, and we'll be sure that the patient received the right treatment without affecting his safety. So we will be sure from the starting from the prescribing that he received the right order, like this. Yeah.
I mean, sharing with you, Ibrahim, my thought about being like within the NRC team, as well as your experience. If you would like to list the top 2 or top 3 guidelines that has to be initiated on a multidisciplinary approach and involving the pharmacotherapy specialist and his role in such guidelines, what are the top 3 guidelines that you will start with?
Actually, the first one mainly for opioid use treatment, the use of opioid agonist treatment, buprenorphine, and we can do the analysis using whether to use the different types of forms. We have the sublingual film, sublingual tablet, or the long-acting injectables, which one is more cost-effective, and how to use it, and the monitoring, and everything related to the opioid agonist treatment. This is number 1. The number 2, in my opinion, we can develop a guideline for the substance-induced psychosis. It is still debatable when to use it and what form, because many medications now, there is no more medication in the pipeline, but now all the pharmaceutical companies, they are developing a new forms. So it is very important to also to have a cost evaluation analysis for all different types of forms for these diseases. And one more thing that can be done also to limit the use of the off-labeled use of some medications, for example, for insomnia, for example, which is a more common in substance-related disorders. So we are encountering many off-labeled medications that can be used. However, there is a lot of some FDA-approved medication that is underused, or we can switch the patients, for example, start not to go directly with the medications, but as a pharmacotherapist, I will not, it is not, as a pharmacotherapist, I will just go with the medications, but also we need to start with the non-pharmacological measures. And there is many O2Cs or non-pharmacological measures For example, melatonin, we can give the patient before going to the medications. Other techniques that can be used. So this is my opinion. This is the three top we can use. Yeah.
I have this question from the audience. How do you treat the withdrawal from MET and AMP?
From the amphetamine, right? Yeah.
Yeah, amphetamine.
Actually,
amphetamine.
Yeah. Actually, still we are. I cannot give a clear answer now because still we are developing a guidelines for this. So maybe after we have the result for us, we can share based on the best treatment approach.
Okay. The other question: how much time do you wait until you request the pharmacogenomics? Since you highlighted the pharmacogenomics part.
To be implemented in the facility?
No.
Or what? The report it will take time.
The pharmacogenomics for the patients.
Actually, it depends. For example, this patients, this is a clear report. We had a problem because we tried a lot of medications, and whenever we were switching from one option to another, there is no response. So that's why we requested this genetic report. And actually, when, as I described earlier, when we saw that the cytochrome B26, the patient was ultra rapid metabolizer, that gives us more clear information, and we were able to choose the right medication for him, and that really changed the patient life. So as I said earlier in my recommendations, so because the genetic report is expensive and maybe it is not available in every facility, so you need also to, you cannot start with giving the pharmacogenetic currently for everyone, but you need to think about it when you really see there is not a partial response, or just when you have encountered, for example, treatment-resistant depression. For example, you may try another options and there is no response. So at that time, you can ask for this report. You need to have a justification. Yeah. Currently, until, as I said, in UAE, we have a big genome project. So maybe after a few years, that will be very easy for us. You will have the genome for everyone. So that will change the map of the treatment.
Okay, I mean, I have a question here from Ahmed. Currently, people here used VELO, benefit or risk. Do you know the VELO, Rahim? Or shall we ask VELO? Okay, we'll explore that and we will
explore it, yeah.
Okay, thank you for that. Do you have any guidelines that you use for the reference that you have shared? Maybe the references will...
Yeah, references down for many reference. Yeah, and there is for example, for the case scenario, this is it was published already. I took it, so there is a reference I listed down in the footer, and for the misconception also there is guidelines. Yeah.
Yeah. The last question, Ibrahim, is how do you treat the cocaine use?
Actually, yeah. This is actually my presentation, because that will take time. So for the limit of time, this is just a principle how to start the project. But for that, we will have a more session about every disease, how to treat, and it will be shared. We'll think about to be a multidisciplinary approach. Me and our physicians will have a look on this.
I believe we're done with all the questions, and we really appreciate your answers, and we thank the team who participated in the questions. So to wrap up, and I would like to thank you, again, Dr. Ibrahim, for answering those questions and for the great presentation. It was a pleasure to have you with us in ISSUP UAE chapter. This concludes the webinar. Thank you all for attending. We hope that you have learned something new today and enjoy the presentation. You will receive the follow-up email within 24 to 48 hours with a link to view the recording of today's webinar. We always appreciate your feedback and suggestion. Please use the link in the follow-up email to fill out the feedback survey. And on behalf of ISSUP and our presenters, thank you for joining us today, and have a great day for the rest of today. Thank you very much.
Thank you very much.
Thank you all.